So we actually have over 10 abstracts, but a number of other activities that are ongoing. The abstracts range from platelet activity with Brilinta, all in addition to outcomes with Brilinta from the Pegasus TIMI-54 trial, as well as some residual data and secondary data from Plato, our ACS trial. In addition to that, some data from our lipid group, including some studies and a late-breaking study presented, which is looking at the impact of the 2013 AHA lipid guidelines on the use of statins and the uptake of statins, both in the patients who need high-intensity statin therapy. In addition, that's some data from some of our other studies with Crestor, including some secondary data from Jupiter. We recently had an additional or an update to our label to include the data from Pegasus TIMI-54, which was in patients who experienced a prior myocardial infarction 1 to 3 years from the onset of treatment in the trial. The study studied 21,000 patients with a prior myocardial infarction who were on a background therapy of aspirin, and the control group getting aspirin plus placebo. In the other arms is the 60 milligram Brilinta arm and the 90 milligram Brilinta arm. And the study was positive for the reduction of the primary endpoint of cardiovascular death, myocardial infarction, and stroke, with a 16% overall reduction, with similar reductions in both the 60 milligram and the 90 milligram arm. As one would suspect, adding an antiplatelet to aspirin, you'll have an increase in bleeding, but there was less bleeding in the 60 milligram arm. And although there was more major bleeding, there was no increase in fatal bleeding or intracranial hemorrhage. We anticipate that anytime you add an antiplatelet therapy to aspirin, and in the other arm there was no additional antiplatelet regimen added, that you're going to see an increase in bleeding. So it was anticipated that you would see that. But the bleeding, although major bleeding, was non-fatal. There was no increase in fatal bleeding. There's no increase in intracranial hemorrhage. And that's balanced very nicely with a large reduction in spontaneous events. So we saw that there was a numeric reduction in cardiovascular death. There was a reduction in both myocardial infarction and stroke, as well as an overall reduction in the composite endpoint. And these are spontaneous events which have long-ranging impact in patient outcomes. So we have a large outcomes trial called the Parthenon Program. The Parthenon Program is made up of multiple studies, the first one being Plato, which was the ACS trial, which showed that and led to the language in the new label, which shows that Brilinta is superior to clopidogrel for at least a year in patients who had an acute coronary event. But then the second study was Pegasus, which was in the prior MI population. Ongoing studies are Socrates, which is in a stroke TIA population, Euclid, which is in a patient population is high risk that have peripheral arterial disease, and Themis, which is in a diabetic secondary risk population. So all in all, they're all large outcome studies, and they were set out to really explore the use of Brilinta in multiple patient populations so that physicians knew how to use the drug appropriately in the right patients. Of course, it's really the physician's challenge, individualize their care for their patients, and they really need to make that choice. The goal really is to identify in patient subsets, at least from these studies, to give them enough information and evidence to make those decisions. I think that we've now identified in patients with ACS the benefits of using Brilinta in those patients with the risks, and they do have to balance that out. And now the prior MI patients, adding Pegasus in, I think it's answered a number of questions. One of them clearly is that patients need to be on longer duration of therapy because the risk doesn't go away. And one of the abstracts that was presented here at this meeting looked at the long-term treatment with Brilinta in patients who had prior MI from the Pegasus study, and showed that if you continued on therapy, that your risk continued to go down. But if you discontinued therapy, you then had events. There's a 21% reduction in cardiovascular events. And what that suggests is that these patients' risks don't go away over time just because you've treated them acutely. They still have ongoing underlying atherosclerotic, atherothrombotic disease, and that their risk persists. I think there are other patients at risk, and I think we have some additional data that's coming out of Pegasus in future studies, in future analyses that probably will tell, and there were some other abstracts here looking at subtypes of myocardial infarction and predominantly showing that the subtype, that the MIs were spontaneous, and they were what we would clinically, as a cardiologist, that I take care of patients, called real MIs, right? They were the ones that we take care of in the middle of the night to make sure that patients don't lose myocardial function. And there'll be additional analyses to somewhat guide patient selection as physicians have to make choices going along. In addition to that, I think the Socrates data in stroke will be really informative, because the use of antiplatelet therapy in stroke patients is somewhat mixed and not really definitive. So I think the Socrates trial is going to be a really important study, one way or the other, no matter how it comes out, to really somewhat clarify what we should be doing with patients with stroke.